mean, I think there's a need for local treatment there, but it's
occasionally, yeah.
I think for pain modification though.
Yeah, right. Well, I think, and that Piriformis example specifically, I'll be honest with you. I try and go to an exercise first.
I will too.
For that reason specifically, whether that's whether you're trying to you're putting the piriformis on stretch, but you're technically hitting the glute, glute max or glute med, whatever, which one, all of them, and kind of devoting a little bit more nervous system attention to that area. And that alone will probably decrease pain anyway, right? That's why general exercise is so good.
You're listening to the Restoring Human Movement podcast, where movement experts discuss the latest evidence-based practices to help you and your clients move with mastery. And now, your host, Dr. Sebastian Gonzalez.
Hey everyone, it's Dr. Sebastian Gonzalez with the Restoring Human Movement podcast. Thanks for being part of the movement. This one is actually going to be a fun one today. We have a guest host on, Dr. Cody Dimak.
Hello, everybody.
So we brought this up because we were talking on Skype a while back, and I said it's really hard to do single podcasts, and he's like, "Well, I think I can make them better," and I said, "You're full of shit."
Yeah, well, just me in general is going to make it better. So
right, because you bring out the best of me.
Yeah, sure.
So just to frame this for everybody, probably the best, probably the clinicians, DCs, PTs, ATCs, strength coaches, exercise science majors are probably going to get a lot out of this. What my major topic was today, and that we thought we'd discuss, is the syndromes, kind of taking a step back from the microscope of the syndrome, and trying to correlate the things together and see if we can. I'm sure Cody's going to have a lot of things to say about this, so I thought it'd be a good one to have him on. You have a lot to say on this one?
Oh, well, do you want me to get started already?
No, not yet. Okay. But
we'll see.
Okay. Yeah. Well, actually, it was funny. So I brought up. Well, I'll wait. So just to make sure that if everyone does like this podcast, give us a nice thumbs up. Or actually, that's not thumbs up. That's a review. Go on iTunes. Go on Google Play. All that kind of jazz, and give a nice thumbs up with a emoji or however you do it, and give feedback whether you like this duet or not. Because if not, I'm going to ditch him so fast, like a rotten egg on a summer day.
Drop it like it's hot.
Right. So I don't know if you know the format, Cody. I got to tell a personal story, and I thought you'd appreciate this one. Did I tell you the curse of the Stella?
No.
Oh, you're gonna like this then, because you're a beer man. So I got this friend who brings over. He always brings over some alcohol to a party, and he's an Asian guy. He gets red after like one drink, so he doesn't really drink. He just brings alcohol. So he'll bring like Kettle One, or bring like Stella, and I'm like, dude, why'd you bring Stella? Right? And he's like, I thought people liked Stella, and I'm like, no one likes Stella. But he brought a 24 pack of Stella. So after this party, no one had drank in the Stella, so I packaged it all back up into a 24 pack and brought it to a friend's house who has a lot of parties. Yeah. So he had a party, and everyone thought, holy shit, he's got a lot of Stella. And they kept buying him Stella. So
everybody kept bringing him Stella.
Right. So it was the curse of the Stella. So you have to give away the curse of the Stella, you have to package it in the 24 pack of Stella and give it to another man who loves IPAs.
Yeah. Yeah. I actually don't discriminate. I'll enjoy a Stella.
Really?
Yeah.
See,
yeah. I could dig a good lager or a good pilsner.
But the foam has the commercial has so much foam on it, they physically have to scrape it off with a knife.
Yeah. Well, not if you just. I don't know. That happens. I think that's just for show.
Well, they're marketing a very foamy beer. It just
showmanship.
It doesn't turn me on because there's only like 3/4 of that glass left after all that foam.
Don't let the marketing bring you down.
Well, they have a glass. They have a gold rim around the glass. I don't know how that makes me feel either.
I have one.
Do you really?
So they give you one actually. So went to chiropractic school at Logan, and so they had they still do, the Budweiser factory there. So we did a tour, And at the end of the tour, you get like one free beer. And I went one time and got a Stella glass with a gold rim around it.
What'd you drink out of the Stella glass though?
Stella.
Did the glass make it better?
It did. It made it more crisp. It was very regal. So felt like a king.
Hey, did you put, those little wine marker things for glasses? Did you put that under yours to make sure no one took your Stella glass when you're done?
No. I called it ale though instead of beer. I felt like it was back in Game of Thrones.
Wait, they called it ale?
They call it ale. No.
Did they have more than one beer, by the way? More than one?
Who's that?
Stella.
No, it's just the one. Stella. Stella's made by Budweiser though. So.
Oh, I didn't know that.
No, yeah.
Well,
it was back in the day. I don't know. If they still own it.
If I owned Stella, I would definitely sell it off. I'll tell you that much.
Yeah, you bring it to somebody's house.
Yeah, just dump it.
The recurse of the Stella.
Yeah, I just gave you all my shares of Stella. You now own the company.
Uh-oh.
So what's up?
Not much, man. Just got home from work, so ready to roll.
Okay. What do you do now, so the listeners kind of know?
Yeah. So formally, if you listeners don't know, my wife and I owned a private practice.
My wife.
In Orange County. Back in Orange County for a little over 5 years, and recently just moved to Dallas, Texas, and I started teaching at Parker University, the chiropractic school out here. And so my position at Parker is a assistant professor of wellness clinics. Basically, I'm a clinician in the clinics, so I have students underneath me as they're going through and meeting their requirements for graduation and licensure.
So they have to answer to you for something.
Yeah, they got to go through me for for treatment and whatnot.
So when they do that, do you grade them on a snotty attitude at all?
No. That's not part of the rubric.
Oh, damn it! Presentation, bedside manner.
Yeah. Well, I mean, if they would have an obvious poor attitude, then you kind of pull them aside and you could probably talk to them and see what's up, But
okay. So so I guess I don't know if I really framed it either. So I wanted to have you on because we have a good dialogue going on. I think you have a lot of good things to share. And
thanks.
And every time we talk, you say that you can make the show better.
I don't say that.
Well, you don't listen to the solos.
But I did say I did not listen to the solos. And I think, I do think it, like you said, I mean, I can see where it'd be tough to just kind of talk for, a half hour to an hour about stuff, especially if you don't have anybody bouncing things back to you or asking you questions and whatnot. So I can see where that could be tough.
Yeah, it's kind of like how you did if you're doing like squats alone versus bouncing a ball against the wall. Like I think I could bounce the ball against the wall longer because you're reacting to the ball. Yeah.
Plus, it's more, depending on the load for the squats, it's more that pulse too, right? So.
Well, I think I could still, even if it was assisted squats, I could still less than
Smith machine.
Yeah, to 0.5 body weight. I think I can do more ball bounces than squats.
Either that, or you could get on the leg press and just kind of flip around instead of laying down, pressing up. You kind of like press. You're like kind of squatting the leg press up.
Oh, you're squatting the leg press down, aren't you?
Up if you flip around.
We'll have to get a picture of you doing that. I know you like to do.
I'm good. Well, I could actually. That'd be a funny fake max performing Cairo.
Well, there you go. Video. You haven't done one of those in a while.
I have not. I need to get back on that horse.
Mm-hmm. So the reason why I want to bring up the lower cross thing today, the syndrome thing today, is because I drew something. I don't know if you even saw that. I can show you a picture. I'll text you a picture. Either way, It describes Yanda's lower cross model, roughly, with some DNS principles, and as well as going down into kind of tonic phasic groups. And to make it really coincide with what patients will ask, they're like, well, I have this Piriformis Syndrome, I have this hip flexor syndrome, I have this impingement syndrome, all this kind of stuff. And I thought, it'd be really nice to show biomechanically how these things are possible and how a minor tweak sometimes can make people feel better.
Mm-hmm.
So I started putting this thing out I put it on Facebook, and a couple people said, is this actually been validated yet? And I remember reading through McGill's book. It hadn't been validated at the time, but he didn't disagree with it.
Right.
And I just spoke to Andy Galpin on a podcast, and I said, what do you think about the fact that something hasn't been proven? He said, that's used in clinical practice all the time, and it should be used because it's multifactorial, basically.
Mm-hmm.
So anyways, I thought we'd go down the syndrome today.
Cool. Yeah, sounds good.
Okay. What do you think? What's your first syndrome that comes to mind to you that you, in clinical practice, you got tired of talking to people about?
Piriformis.
Why is that?
Just because it's almost always never the piriformis.
Can you dig deeper into that?
Yeah. So it's kind of like a blanket diagnosis, like plantar fasciitis, right? So I think there are ways to determine whether or not it's actually the piriformis, involved in any type of radicular symptoms. A lot of people think that just because they have kind of like deep glute pain that it's the piriformis, and they haven't ruled out the hip and or even the disc in the low back. Michael Shacklock has a portion of his slump tests. You can actually tease in or out piriformis involvement in the slump test too, with the internal external rotation of the femur as you're taking the knee into extension and putting tension on the nervous system, right? So, on the sciatic nerve rather. But I mean, it's just a blanket diagnosis. So when people would come in with Piriformis Syndrome, and all they're doing is they're shoving a lacrosse ball into their piriformis, hoping it'll go away. The irony is that Piriformis Syndrome is usually active when the piriformis is long, and so they're trying to stretch a muscle that's already too long. And so if the nerve pierces the piriformis and that's actually causing the problem, they're like stretching it, hoping that and just putting more tension on the nerve, if there is that, right?
Yeah. Well, so is there a way then, do you see when there's actually what percentage do you say is actually a piriform, like would you classify as a piriformis syndrome?
I haven't diagnosed one.
I haven't really either. I'd say in the past I have, and I would say they responded to tissue work, but not over long term for me.
Yeah, I've actually had one patient, but she was older. She was kind of in a potentially stenotic group that you would classify. And your differential is what pops in your head when you look at her age and her activity and stuff. I did soft tissue on this, more so a posterior capsule. I'm sure there's some piriformis in there too of the hip, and it felt good. But really, the thing that got rid of her kind of radicular symptoms were just static openers, putting her in a static opener position for the low back, just kind of creating a little space in the IVF, and that really relieved her pain. So I'm not saying that you're not going to potentially address maybe soft tissue problems in the posterior portion of the hip, but a lot of times that's not the driver.
Right. So I think that's a major point, because I think I'm actually I was going to write a huge article based upon these syndrome correlations and biomechanical postural changes and see where we can tie them together. Right. But she said it's really not the driver, and it's but people really hang up on that, and I think a lot of clinicians still hang up on that. They're chasing that spot,
Yep.
So is there? I mean, I think there's a need for local treatment there, but it's
occasionally, yeah.
I think for pain modification though. Yeah.
Right. Well, I think and that Piriformis example specifically, I'll be honest with you. I try and go to an exercise first.
I will too.
For that reason specifically, whether that's whether you're trying to you're putting the piriformis on stretch, but you're technically hitting the glute. Glute max or glute med, whatever, which one, all of them, and kind of devoting a little bit more nervous system attention to that area, and that alone will probably decrease pain anyway, right? That's why general exercise is so good for everything.
Well, that's why I think so. You brought up the Shacklock stuff too. I usually go to an exercise first just to see if an exercise or some type of differentiating factor to I don't want to prove to the patient that they're wrong, but I want to provide some type of doubt that we're not going to keep doing the same stuff that wasn't working for them.
Yeah. Well, I think too, that becomes part of the attempt to try and empower the patient to play an active role in their healthcare anyways. You know, I mean, because if you can do one exercise, I mean, obviously this is after you've done your very, very thorough history and exam and a movement evaluation. If you think this one exercise is going to be a place to start, that's why you do the exercise and you retest to see if you've made a change. And if you haven't made a change, then you try something else, you know?
Well, she know, I forget I was talking about this actually, but I remember when I came out of school, like we got like, say, a Piriformis Syndrome, and we would beat the snot out of it, and the person would feel better, and they say, oh, that's the spot, you know? But I think over the last couple of years, I've really been happy with being able to make people feel better without actually touching them. Yeah. And the interns that I have come in, they're like, they don't seem to think that that's possible. Right. And I don't want to say like it's voodoo, because I don't think there's any voodoo, but can you explain biomechanically how you feel like an exercise or something like that would correct this problem, make them feel better?
Yeah, I don't know if it's necessarily correcting the problem per se. I think it's more so of changing what the brain's perceiving as normal. I mean, you're kind of doing a lot of factors here, incorporating psychosocial factors and just movement in general, playing with that stuff. Because if you can do an exercise that doesn't necessarily reproduce their pain, but maybe fires up or facilitates a muscle or something like that, and that takes away their sensation, you know, and you're changing what their brain's perceiving as kind of what the normal state is.
I was going to take a different route. I was going to go support, like building a supportive system, so it decreases the amount of load on the structure that is the pain generator. Maybe.
No, I think the big thing is maybe, right? And so mechanically, that would be biomechanic wise, that would be the theory that we're trying to hit, you know? So, you know, an example of Piriformis Syndrome, we're suspecting there's some type of lumbar involvement that's referring to the area. We've ruled out a actual hip. Of course, piriformis is tender to palpation. I don't know a person who doesn't have a piriformis that's tender to palpation, you know? We take those individuals and start doing some sumo or monster walks with a band around the fifth metatarsal, the base, and to facilitate some external rotation from the hip, and have them do, like, you know, lateral band walks, facilitate glutes, and, you know, they're keeping relatively good posture and position. I'm not having them brace super hard, you know, or might even have them brace. I'm just trying to get the glutes fired up. So mechanically, you know, we're taking that approach. We're letting the brain know, hey, we can use the glutes now. We don't have to rely on, you know, piriformis to be our, you know, our stabilizer of the hip.
So I think, to clarify on that, because I think I led that route a little odd. I personally think that majority of piriformis stuff is neurologically based, which makes the nerve fire up piriformis. I know I said piriformis might be loaded, but I think I misspoke on that. So you're talking about getting the glutes to work and tell the brain there's no threat. The glutes are probably working if they're standing. So yeah, well, that's a whole. I guess there's a whole other conversation. I guess there was actually when I put the thing out on Facebook today, someone sent me something that Lehman wrote about a couple articles that were not supportive of lower cross, and basically talking about how, I think it was that glutes were not actually weak. They were actually strong on people that had short hip flexors. And so I know that everyone's kind of going on that route of the weak and strong and facilitated and not. And I don't even know if that's, I feel like a lot of it is just like neuro-based, like what I've found.
I think so too, yeah.
I don't even know if any of them are weak. They're just
right.
They're guarded.
Right. I mean, exactly. Well, I don't think you're really going to have true weakness unless you have like neurological deficit, right?
Yeah, big deficit.
Yeah. You were literally like a big, you know, foraminal encroachment or something that's literally cutting the blood supply off the nerve where it's not working.
So with what type of presentation, I guess postural presentation, would you say a piriformis person usually is? Are they usually flexion intolerant, lumbar spine? Are they rounded forward? Are they open? Do they fall into the category of lower cross at all, or?
Are you talking about the ones who have legitimate piriformis syndrome?
Oh, yeah. Shit. Posterior hip pain that they perceive as piriformis.
I mean, I think you could have both, right? In terms of like a lower cross, or even just a kind of somebody would classify as not lower cross, or excessive anterior tilt with pelvic tilt with a kind of like a anterior superior rib position. I don't know, and I don't know I've only read like maybe one or two research papers about this, but I mean, I think DNS would say that kind of open scissor posture, lower cross syndrome, theoretically will take the posterior portion of the bodies of the vertebrae and kind of soften the disc in the posterior portion. And if you look at McGill's work, he would say repetitive flexion with and/or flexor rotation over time could create a disc bulge, and he but taking that too, I mean, if you take those two together, maybe it can create some potential potential threat to the posterior portion of the disc to produce pain, and that may refer to that area of the piriformis, so to speak. So that's an option. I mean you got to consider everything, right?
Mm-hmm. So then, just to kind of wrap up Piriformis Syndrome, I guess a little bit is, I guess to tell you what, probably the thing that I would try first is to see if a torso. I usually get them to sit or stand or lay or wherever the hell they're like. I don't care which position that they're in. As soon as they say this thing started to hurt, then I'll cue usually torso stiffness, or I'll take their spine or go to the side of them and give them a little support and move them forward, backwards, side to side to see what happens, right? Or I'll just hug them around the pelvis and see if me compressing the pelvic ring together assist. So we don't have any. So I kind of know that we're not hunting down just a muscle tear.
Right. Yeah, totally. That's a great. Yeah, I use the same similar to differentiate between that. If I really think it's something a disc going on the low back that's kind of causing their pain, I'm going to try and find the things that trigger their pain and see if we can make a change right then and there. And now we may have to modify their activity for the time being in order to let that area kind of calm down. But the ideal scenario for everybody, I think, is try to get them decrease their fear in moving. And but sometimes that does take a little bit of coaching of activity modification and kind of distributing the load amongst the rest of the body or the joints above and below. Specifically in this scenario, probably the hips. Maybe
but the piriformis, man. But you can't move the hip. The piriformis.
Well, you got to use the lacrosse ball or something.
Yeah. Well, you kick it.
Shove it in your pec. That trigger point. That's a compensation.
Well, that compressive therapy's got to work for something, right?
Yeah,
So as we go down into, actually, just to catch myself, I'm realizing I'm going into interview mode and we're co-host. So if you guys, I'm screwed. So I need to make sure to tip that since it's the same. Let's go on IT band next, because I think it's probably going to be very similar.
Yeah.
I know my perspective on IT band is that if it's actually around the focal point around the knee, around the lateral femoral condyle, there's a possibility we're looking at it actually. But if it's up and around the thigh and the TFL and all that kind of jazz, and it's correlated with a grumpy back, I would differentiate the back first as a nerve-based one.
Absolutely. Yeah. Yeah. I think the IT band gets a lot of bad press. The IT band's just there, kind of hanging out. The IT band's formed by the tensor fascia lata. All it does is tenses a lata fascia. So Yeah,
You teach an anatomy class or pun class over there?
Yeah. Yes. Puns are necessary when teaching the students. But, if the TFL is kind of being overactive, the IT band has no choice but to be tight, so to speak. But I mean, I think there's some research, and I'm going to really mess the number up, but it takes thousands and thousands of pounds to deform the IT band. Mm-hmm. So foam rolling it is kind of marginal if you're thinking that you're lengthening it.
Mm-hmm. Why do you think people feel better after they're rolling it?
I mean, you're literally stimulating the skin and just the muscle fibers, right? Mm-hmm. So kinesthetically, it's creating a little bit more, potentially a little bit more awearness around that.
There was a lady that came in the other day that actually I'm not going
to get into the Pacinial corpuscles or anything like that.
No, we don't have to go crazy. We got a lot of syndromes to cover, and I'm looking at the time. I had a lady actually come in yesterday and actually this happens a lot. So I sit at the desk at the very end, and I'm talking about
ladies coming in your office.
Ladies coming in, ladies coming out. But they're sitting there, and so she had a shoulder thing, and she kept going like this to it when we were talking. I'm like, What are you doing? She's like, oh, sorry. And then we talk a little bit more, and she's like,
so you're rubbing again, huh?
Yeah, she keeps rubbing it. And I'm like, that's a normal response. Don't worry. Don't freak that I don't want you to do it, but we've already gone over 4 things that make you feel better almost immediately. And it wasn't rubbing wasn't one of them. So please.
Was she just checking to see if it was still there?
the shoulder itself?
Yeah.
It wasn't
the pain or the discomfort.
Maybe. Yeah. Have you had those people where they get numb and they can't feel the numbness unless they touch?
Yes. Yeah.
Yeah.
Yeah. Mostly in lower extremity though.
Yeah, that's where mine were.
A lot of post-surgical, post-knee surgical things. A lot of those, kind of like the shin and stuff.
So to find that it was improving or not, did you go like this? Did you keep touching them and then doing stuff?
No.
Oh, I did.
No.
It was working. I needed to find out better versus same. So,
well, if it cut the nerve, then it's probably not going to come back. So,
well, these ones weren't post surgical.
That's different.
Yeah, one did come back. Actually, it came back within a couple minutes. I was surprised. It wasn't the primary complaint.
Yeah.
So
Seb, I got a question for you.
Oh,
kind of lead into IT band. We already kind of got into TFL a little bit with the IT band. What about your super common presentation of hip flexor?
Oh, the hip flexor?
Yeah.
This is probably better on a video demonstration.
Now, hip flexor.
The hip flexor syndrome.
Yeah.
Well, I mean, so first off, I think people feel that. Go ahead.
Specifically, tight hip flexors.
A tight hip flexor. My thought is that number one is they feel that anything on the front side and the anterior groin, they feel like it's a hip flexor, although it could be impingement is one thing. And so I got to rule that thing out anyways. And that would be with Scour's test, circumduction, Faber's test. Those are all real nice to try. I'm sure there's a couple more, but I'm not going to name them off because I don't want to dig that deep. But in regards to, I always do a demo with this, and I say that if the hip flexor's job in this case, if you are trying to say it irritates them to flex their hip, I say that can only bend your hip and flex your hip up if it has a stable point to move from. So I usually find random shit around the office. I'll be sitting in a chair and I push, that rolly desk you gave me?
Yep.
So I'll push it and I'll be more stable than it, so it moves. And then I'll take myself against the desk that is more stable than me in the chair, and then I'll move in relationship to the desk. So I tell them it's based upon the fixed points. So usually when I see people with the tight hip flexors, I find that the torso is not stiff enough to manage the contraction potential. That's just me, though.
Yeah.
I'm sure there could be a neurological based, what is it, L2 through 4, I think that goes in there.
Right.
But those are all torso stiffness corrections for me anyways. So if I know I'm going in the right path, then it's the same. But I usually don't dig on them first. What do you think?
Same. Yeah, I don't really attack those soft tissue wise at all. But you get a lot of people come in with the tight hip flexors, and I say, okay, well, what are you doing to help with that? And they're literally bringing their knee up trying to bring it up into the armpit to stretch the hip flexor.
What are they doing?
So they're literally flexing their hip and pulling their
to stretch your hip flexor.
Yeah. I'm like, what do you? That doesn't make sense.
They're probably trying to blow through that impingement point.
But they're when they do that, they're yeah, it's tight right here. And so they feel the tightness or stiffness in the anterior portion of the hip when they go into hip flexion. And it's the same if they lunge or if they squat, So obviously it's not a muscle tightness. They are getting that type of potentially type of impingement, like maybe a functional impingement where it's more soft tissue and it's not bony, like a pincer or a cam impingement, So, but the sensation, if people are having sensations of things being tight, if they're standing there like, I just kind of feel tight in my hip flexor generally, there's obviously something's going on in terms of something's overworking, right? Or it's trying to do the job for somebody else or something else.
Yeah. I know you've always been a big one of, does it feel tight or is it tight?
Yeah. And that's a question I ask everybody because they're different, right? So something can be truly tight. Usually people don't feel true tightness. They don't feel like my left gastroc and soleus are legitimately shorter than my right from previous disc herniations. I don't feel the tightness until I put it under tension. Same with the lateral hamstring group in my bicep femoris group on my left side. All that's atrophied from previous disc herniations, and I literally don't feel any tightness unless I put it through a legitimate stretch. Now, a stressful day, my neck feels tight. It feels tight, it feels stiff. But sometimes when I feel that tightness, I literally just relax my stomach. Sometimes the tightness goes away, and I haven't done anything to change the position of my neck. Yeah.
Well, even too, I think I know this goes into like the upper portion, but just cervical distraction a lot of times in those people, or a little chin packing will decrease it. And in that case, let's say cervical distraction, in theory, the muscles would be lengthened.
Right.
So it should make it worse.
Correct.
So, I think of the definitely differentiating factors to figure out what we're actually addressing with these people, whether they think their stuff is tight or not.
Yeah. I think the big take home is the perception of tightness isn't always tightness. And if you try and stretch something that's perceived as tightness, then you're kind of, it's more, you're looking at potentially something more neurological, not necessarily not a disease or anything like that, but just maybe some hypertonicity.
Yeah. Well, I think too that after going to that shot clock course, I think something after talking to patients about, like I said, this is a neurological based condition. I think they have a knee jerk reaction and thinking about this does not feel like sciatica. I've seen someone with that. It's not that bad. It's like, well, and we talked about just the amount of pressure that it takes to occlude a vein is all it takes to swell a nerve and create ambient responses. So. I think the public also oftentimes thinks that it has to be excruciating, electrical, all that kind of stuff.
It doesn't, no.
Yeah.
It doesn't. Well, that's what the textbook says too, right? And so that's, in school, that's what you learn. You learn that straight leg raise at a specific degree, only within a certain degree range, if you is positive if you get the reproduction or a searing pain all the way down the back of the leg, down the calf to the foot. That's what the textbook says. And if you are above this certain amount of degrees, then it's SI. And if you're below it, then it's hip. Or vice versa. I don't really.
No one you ever see gets past that range, right. Anyways.
It's you have to take into account the sensation of tight, like a sensation of a tight hamstring too. You need to Shackleck calls it differentiation. You have to differentiate between whether this is muscle or whether it's neuro. And that's what you try and when you look at any neural tension tests, whether it's for upper extremity, lower extremity, when there's any sensation or anything, you have to wiggle the nerve from one end or the other to see if that discomfort or that sensation goes away. If it goes away, then it's not something locally where they're feeling it, right? In this case, in the straight leg raise, if you take it down, or if you if you flex their hip and they get a tight hamstring, and then either you have somebody lift their head into flexion, and or you lower it, and then you dorsiflex the foot, you're changing the dynamics of the nerve, but we're not really changing too much dynamically from the hamstring aspect of it. But some people might say, what about your fascial slings, yeah, you could take that into consideration, but Shacklock has the option too for, in slumps, to pull the other leg or pull the other leg up, which will move the spinal cord, or the arm, right? Move the other arm, pull the spinal cord. So you can kind of use that as your differentiation too.
Yeah. Yeah, and definitely those differentiating things. I leave it to the imagination of the person. Whether I said there's no muscle that's going this far. So if you think you got a muscle syndrome thing, it's not. It's vessel, it's nerve, fascia, or I forget the other thing I say, but it's make believe. It's like it shouldn't change it.
Right. And I think people might be listening. They're kind of wondering, what does this have to do with any type of syndrome stuff? But these are all factors that you need to consider when you're potentially looking at a syndrome, right? Is this really a result of a positional thing, or is this a perceived thing in the brain, or is this a response in the area from perceived threat? Right.
I don't know if I sent this to you or if you saw it, but there was this was, I think it was 2012. It was the I'll pull it. So it's called 2012. I'll put a link to it in the show notes for everybody who wants it. Terminology and classification of muscle injuries in sports, the Munich Consensus Statement. Did you read this one yet?
Is that the hamstring one?
I don't remember it being hamstring based, but they broke it down into.
I think I remember reading that, but a long time ago.
Instead of type 1, 2, 3, it had subcategories like 1A, 1B, 2A, 2B, and so on.
Okay.
So here's the basics, though. Type 1, type 2 were basically we could consider functional. And the reason I'm bringing this up in regards to syndromes, if we bring this back to, say, the piriformis, because everyone thinks they'll think they'll have scar tissue in there or all that kind of jazz. And actually, and this happens to a lot of people. They say like I did this MRI and musculoskeletal ultrasound, and they're negative. It's like, well, what the hell do I have, right? Like I was told I have scar tissue in there. I was told this piriformis is tight and fibrotic and all this stuff. And the type 1 is type 1 and 2. They're dom. Like so, type 1. I'll read them off. Type 1 is overexertion related muscle disorders, fatigue induced or DOMS. Like no one's going to find a positive MRI of DOMS, right?
Right.
Or delayed onset muscle soreness.
Not that I know of, anyway.
I don't know that I know of either, but based upon this, they would say no. But no one freaks out about DOMS either, And type 2 was neuromuscular based disorders, so spine related or muscle related. And one of their specific examples was sciatica with tightness of the hamstring. We're going to find negative MRI and ultrasound findings, but certainly type 3 and 4, which are partial tears or direct muscle trauma or total tears, we're going to find positive findings, and that's a reason to get into tissue work a little bit more. But the indirect ones, we can certainly find some type of maybe the nerve related one or the spine related one. That's something that you would differentiate with contralateral leg movement or the Shacklock work.
Absolutely.
And maybe it would work under or maybe a McGill model or a DNS model where you build supportive systems.
Yeah.
So,
or you can utilize, something that works really well. I use day in, day out for if I suspect some type of a disc thing is, some McKenzie extension stuff. You could put them in passive extension, either have them knock out a few press ups, or you could just have them sit in passive extension, and then you could retest. And if there's a change in symptoms right then and there, you didn't do anything to the hamstring.
Mm-hmm.
We didn't just stretch the hamstring, and all of a sudden now you have more mobility at your slump or your straight leg raise with less perceived tightness, right?
Mm-hmm. That's when in doubt, press it out, right?
That's it. Well,
yeah. It just looked like you were doing a pit bull imitation, and you had a BL in your hand.
Oh, the lime.
Hey,
lime.
yeah. Oh, they have like strawberry now.
It's orange. It's orange.
It's so gross.
But like orange.
Oh God, what are they thinking? Like they were making a michelada?
No. No.
Okay.
No, but so kind of keeping on staying around the lower extremity. I think are you thinking that some of these like piriformis syndrome stuff, or some of these hip flexor tightness things, so you think that's a result of what Yando called lower cross syndrome?
Well, I think it's a possibility, but the problem is I drew this stuff because it's a conversation I have a lot, And obviously there's always the depends situation, but it's I find it's really common, but it doesn't always have to be that way. But I think that I find that when someone has one syndrome, they also have aspects of another syndrome. Or they'll say their hip flexor is tight, or their piriformis is tight as well, and they've experienced knee issues. And it's like, where's the common meeting point here? Like, we can chase these things down in a damn microscope, or we can look at a broad picture.
Right.
So I want to find the broad picture on this, or at least I want the listeners to be able to think, rather than give this person 5 corrective exercises or treatments for like the piriformis and one for the other hip flexor and then the knee, and then they got this foot thing. It's like, where's the common ground?
Get 3 or 4 birds with one stone, hopefully with a good exercise, and preferably, when for treatment wise, our goal, and I'm sure yours is the same, is when they come into us, we're trying to give them what they're going to use to warm up before they train.
Pretty much.
And if we can get them to train as fast as possible, we're hitting our goals.
Mm-hmm. And we can definitely, and I keep coming back to the tissue work because I know there's going to be a lot of tissue work people out there. I don't think there's anything wrong with tissue work, but they can't really do it on their own.
No, they can't. And sometimes it is necessary though, right?
Mm-hmm.
But I think if we're leaving a lot on the table if we're not educating the patients in terms of not just what's going on, but what the plan is. If all we're doing is relying on our manual therapy, whether that's soft tissue or adjusting, we're missing a big piece of that.
Yep. And if we do have a true, I think, piriformis that is getting traumatized, or a hip flexor that is getting traumatized, we have to stop the insult. And I think we're going to do that with some type of supportive system or movement modification, really.
Mm-hmm. Yeah.
Facet syndrome. I know you talked to me about that the other day. What do you think about Facet?
Yeah, Facet syndrome. Facet syndrome. I'll be honest with you, I personally haven't diagnosed Facet syndrome. Most of the what people would call non-specific low back stuff usually diagnose as Facet syndrome. I see a lot of times Facet syndrome being diagnosed when in fact they actually have some type of underlying disc issue. And since there was no full-blown radiation down the leg or your classic what you would consider sciatica, they're not doing nerve tension tests like slump and or straight leg raise and Braggart's.
So can you explain that? Because usually disc or flexion intolerant Facet syndrome is usually extension, I believe.
Yeah.
According to Wikipedia, anyways.
Right. But you see that, I mean, that's kind of a blanket. People are seeing, they're diagnosing Facet syndrome whenever there's just back pain with flexion, and even if you have an angry disc, you can still have back pain when you go into extension, but it's going to feel different. It's going to be more pinpoint toward midline of the spine, where maybe a Facet syndrome might create that classic what you've learned as almost like a kind of like a referral pattern when you go into extension.
Mm-hmm. Well, I know that I was actually in the course of writing that article this morning, and I looked up Wikipedia's 4 criteria for Facet syndrome, and one of them was...
I'm glad we're using a respected source here.
Well, this is what the public's reading, isn't it?
Good point. What does Wikipedia say?
Oh,
did you go through Dr. Google first?
So to be fair, I could easily go through all of the like research-based crap and everything, but realistically, I think the problem is like when people come in and they're reading that this is what they're getting exposed to. So, and I know everyone bitches and complains about like all the noise on social media and like these gurus don't know what they're talking about and blah 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 and all this stuff. It's like unless you drown them out with better stuff, it's not going to change. So no. I'm trying to figure out what they're already seeing and change it. So Dr. Google says, number 1, trophic changes in the skin, referred to as cellulalgia. Actually, I hadn't heard that before. Patient will not be able to feel, or patient will feel pain at correlating spinal levels with facet will not feel correlating pain levels at levels with facet palpation, imaging unremarkable. Local injections into the correct facets will seem to decrease symptoms, but basically it seemed like it was a hunt since the person can't really identify them anyways.
Yeah.
So,
yeah, I think we have better tools to identify a potential disc issue.
mm-hmm.
And just in terms of assessment and really history. I mean, gosh, so you miss so much on the history, because if you don't have a really good, thorough, long history, and you ask a question and somebody says, if they answer you ask an open-ended question, hardly anybody pulls that string and starts unraveling the rest of that, goes down that path. And you're making directed, open-ended questions for specific things, and if they answer no to that, then you move on, but that takes your differential and cuts it down almost more than in half. So, and then your exam is going to be much more efficient. And I just think we're better at detecting a potential disc problem than we are a Fassett syndrome.
How long would you suggest your history taking process be?
Including review of systems.
Let's X out review of systems.
It kind of depends on if it's pretty clear cut. It could be anywhere from 15 to 20, 25 minutes.
Mm-hmm. Okay, I'm much longer, mainly because of hearing concerns and all the other stuff. It's more of a relationship thing.
Mostly hearing concerns.
Mm-hmm.
What?
I do have hearing issues.
Yeah.
But what's the typical exam time what's the criteria in the boards now? I think they have to go through their part 4 and have an exam in 12 minutes or something?
Oh, I actually don't know that. I guess it would be good for me to know that right now.
I thought it was under 15.
12 minutes. Wow, that's impressive. Do a thorough exam. It's funny. When I first started practice, I was like, man, an hour's, because I had an hour new patient visits. I'm like, an hour's not enough. I can't fit it in, and then a couple of years in practice, I'm like, I can knock this out in like 45, 50 minutes. And then after that, you start to learn a whole lot more, and you're like, I need an hour and a half.
Yeah.
It's funny how it kind of swung from one pendulum back to the other. But I'm still kind of leaning towards like that hour and a half, if you're really going to do it. Now, this is including what some people, review systems, history, assessment, orthopedic assessment, neuro assessment, functional movement or a movement assessment, and like a kind of brief little report of findings, let them know what you found, or you could do that as you're going with the assessment,
mm-hmm.
and then and typically in practice you might make an intervention right then and there, give them one thing to do, or mix of activity or some activity modifications, or basically teach them how to avoid their painful trigger, essentially.
Yeah. I've gone to about an hour as well. I'll fit a bunch of stuff in it, and I usually screw up and don't actually do a bunch of documentation yet. Like I got to do it later. I got to dictate it, which I guess in all honesty, then it takes me about 2 hours for a new patient processing and exam and pain modifiers and exercise and blah, blah, blah. But I try not to go through tissue work the first time, because I don't want them to feel like that was the only thing that fixed them, because someone else has already done that with them.
Right. No, and that's when people came in to see me in my practice in California, they've already seen, 3 or 4 people, sometimes more. And sometimes I was the last stop, or they've already had a couple surgical consults, so they're just looking for something new, or they heard that he's a chiropractor, but he's not really a chiropractor, but he is a chiropractor. He just does different stuff.
Start your new practice called that, chiropractic, but not really.
kind of, but not really. But I am.
Yeah.
I am definitely a chiropractor. So, but no, they would look for something different, and I would give them something different, And every now and then I would have the person come in expecting kind of what a traditional chiropractor would do. But that was the precedence was set before we even got into the exam. After I took the history, one of my questions that I asked new patients was, what are your expectations of me in terms of like my treatment and what do you expect from me as a doctor? And so we got it all out on the table right then and there. If they're in just to get adjusted, then I told them, I said, look, that's not what we do here. This is going to be different. We're going to do some exercises and that type of stuff. And if that's something you want to try, let's get it. If it's not something I fully understand, and I can help you find somebody else if you want, if you want, if that's what you want, so.
Did, and I don't know if Ben talked to you about this topic yet or not. No.
No.
So we talked about this because I used to would get a lot of phone calls of like, hey, I just want a quick adjustment. I'm like, oh, this is the worst. Like,
I think I've talked to Ben about this, but go ahead.
Yeah. So yeah, he's like, I take them. He's like, and I'm like, well, why? And he's like, they're paying me to market to them of the things I think they'll work for them. And he's like, I'll spend a couple times doing what they want, but he's like, look, what if I taught you how to do this, and you feel better all the time? You don't have to pay me for it. So that was his edge in, trying to meet them where they're at. So I get it.
No, I get it. No, I do.
But I don't think they would last an hour and a half talking to me and not adjusting it.
It's the principle.
Yeah, I know. So back on the syndromes here, let's go further down the line, because I know that we already talked about impingement of the hip. We talked about hip flexor, piriformis, IT band, and I think we should talk about patellofemoral pain syndrome. How do you think about? You want me to start on
that? Sure. Yeah. What do you think about patellofemoral pain syndrome?
Well, I think
I am curious, actually.
Oh, really? So, because we have never talked about knee stuff.
I don't think we talked. No, go ahead.
Okay.
I don't think we have, actually.
So my theory is kind of based upon what was the work that Powers did in 2007, maybe 2009. There was a dynamic MRI. That was a weight-bearing dynamic MRI, and so versus recumbent or supine ones, non-weight-bearing. And so what they found was that the patella didn't move laterally; the femur rotated under it. Yeah. Right.
Yep.
So then that obviously comes from the hip. And this I haven't clarified yet, but I have a respected source that he believes this, and he's a super nerd like a Sheldon. And I said, how do we control femoral internal rotation? And he says the ilium is the boss. Mm-hmm. And I said, okay, what attaches to the ilium? And that led me up to the lower cross again.
Well, let's revisit that. What attaches to the ilium that attaches to the femur?
What attaches to the ilium attaches? You talking about the glutes?
Yeah.
The piriformis. The piriformis is the answer to everything.
So what is whenever the femur goes into internal rotation or valgus collapse?
Deceleration via. Yeah. Oh, wait, you asking or telling me?
I'm asking you.
Oh, okay. Eccentric control of the lateral rotators.
You are almost there. So in valgus, right? So the technically you're right, but be a little more specific. Valgus collapse at the knee. Well, that study was the foot in contact with the ground.
That was standing, so I hope so.
So the foot was in contact with the ground, which is an important thing, right? So when the foot's in contact with the ground, the valgus collapse. Let's say the valgus collapse happens. So the femur is going to the flexion, internal rotation, and adduction. Literally the exact opposite of that is extension, external rotation, and abduction. What muscle does those actions?
Are you talking about the max?
Glute max. So it's the eccentric control of glute max, right?
I think they all work together though in that. It's just not hard to separate that. Plus now we got QL, the torso.
Well, opposite QL.
Yep.
Yeah. So contralateral QL. It's not always one muscle, right? But if we're looking at a big driver of potential valgus, you can't pass that one up. But again, does that come back to, is that a core stability thing? Why isn't the glute max or the glutes or whatever's controlling the femur? How come it's not doing its job?
Yeah.
Is there an actual foot or ankle problem in order to, and where we're not having the glute be as efficient as it can be. And I think we can kind of pick this apart all we want to, but if sometimes that we need to address the minutia, but most of the times we don't. Mm-hmm. And I think if we can find a painless range, or we can find a way they can load a painful area with no pain or minimal pain or some just discomfort, nothing above we try and stick around a 3 or less. I think you're going to get more bang for your buck anyway.
Mm-hmm. I agree. Do you have a good way of explaining patellofemoral pain as you're exploring the upper parts of them to a patient? Because it might seem kind of like, hey, pay attention to my knee, man.
No, I literally say, okay, so this is what we think's going on here. So whenever you're doing X, Y, Z, and your foot's in contact with the ground, until it's almost like we're losing control of the thigh here slightly. So what we're going to do is we're going to do some stuff to kind of help support that thigh, and do some stuff to help support what attaches to the thigh, and really just kind of try and train some movement patterns and find some good exercises that you can train the whole thing and get this better.
Okay, that's good. I usually sit them down on the table, put their feet on the ground, and I put my hand in their hand, and I say, I'll give you $1 if you can push me away without using your belly. And so I've never lost this bet, except for one time I was close because they were on the ground pushing up, and I'm not going to let them lay down again. They got to be seated. So I say that the hip, the knee, and everything below it also works the same. All the extremities work the same. You have to have we have to start at the center, and that's it. Mm-hmm. And then we go and play around, and they tend to feel better. So then they stop questioning it. Yeah. Is there more symptoms one that's a tangent that you might be familiar with now is pelvic separation? That's a pregnancy one, huh?
Pelvic separation. I have no idea.
Oh,
I'm not pregnant.
Marianne would know that one.
My wife's pregnant.
My wife!
Yeah, so I don't know about that one.
Oh, yeah, I think that one happens with pregnancy, and they get like the looseness of the pelvis or the pelvic ring, and then
pelvic.
Pelvic. Oh, what'd I say?
Public.
Oh, yeah.
They said public separation.
That stopped in the 60s, apparently, according to law.
I was like, what are you talking about? Talking about a tangent. This guy. Pelvic separation. So you're kind of talking about just kind of loose bolt. I
don't know. I haven't done a lot of research on this one, but I feel like it's just the ring is loose for whatever reason.
Well, I mean, you are getting ready to push a mini human out.
Yeah, but it remains. The people that I've talked to said they have that, and they're talking about a year after.
Yeah. Yeah, I don't know. I don't know if I know enough to really comment on that. Mm-hmm. I mean, if you think about it from a mechanical standpoint, maybe it's depending on the size of the mom and the size of the mini human coming out, that may play a role in how much the actual pelvis did have to distract, and then your activity or probably lack thereof activity, depending on how traumatic the birth was after the birth. I think all of those will probably play a huge role in those. Mm-hmm. In that.
Okay.
And your activity, and maybe even your activity leading up to it.
Yeah. I don't know much about that one, but I feel like it's. I
think Marianne would probably have a better answer for you on that one, honestly.
Yeah, no, I think so too. We talked a little bit on the phone about it, but it was Since we're in the syndromes, I thought did we miss a syndrome here? I want.
Lower cross.
What was it?
Just lower cross in general.
We talked. Well, yeah, I guess lower cross in itself is a syndrome. Mm-hmm. Yeah, I hate to call it lower cross. I mean, I hate to call it a syndrome, honestly. I feel like, I imagine the dials, and that's the whole thumbnail of this show is the dials. So let's just dial them back, close it down. I don't know, center point.
What's going to be your entry point for that, for the close it down?
For the entry point for any of these syndromes?
The lower cross, to close it down.
For lower cross, I'd probably start with. I've been starting with a dead bug, honestly, or some type of like supine breathing dead bug thing.
Mm-hmm.
I don't know what you call this stuff, but if you were to load a dead bug and go hand on knee, contralateral, and then have them press in and supply their own load.
What are they pressing in by?
They're pressing the palm, this part, so the thenar eminence into the thigh of the contralateral leg.
Yeah.
In a dead bug position, as have them breathe into a floor. So that's not really where I've been starting, but I like that. That's a nice starting point for people.
Yeah.
I mean, I can go into like some of the DNS stuff and face down and all that, but like some people don't tend to get it as much, and I don't always have time to teach it yet. So I think the supine dead bug is a nice one to start for me. Where would you start?
I'll be honest, I never did dead bug.
Really?
I did the true dead bug. I thought it was too hard to coach, and not that many people were good at it. And whenever I thought they would be good at it, I think I found that we should have been kind of moving on to other stuff anyway. If I really, really do think that it's something that needs to be addressed in terms of actual posture and positioning, I'm not trying to have them statically change and hold positions, when they're just kind of doing their daily activities, but I'm trying to expose their body and their brain to a new position. I coach rib position only, really.
Mm-hmm.
I don't really do a lot of pelvic positioning or pelvic tilting at all. I think if you can control the ribs, then everything else can probably fall into place a little bit better.
Mm-hmm.
And I try to pull them away from that as fast as possible. But I will, they kind of, if they have a problem with kind of rib position, or if you look at, some DNS stuff, that they have that poor ability to kind of fill in intra-abdominal pressure in the posterior lateral portion of the trunk. I put the Core 360 belt on them and have them kind of breathe into that and brace into that, and then we could go do whatever.
Mm-hmm.
And so I don't have to keep cueing or anything like that, and wasting my words.
You don't have extra fingers to just stab into their sides?
No. I mean, I think when the one, again, even the person, Erin McGuire, who created the Core 360, she doesn't want you to use that as a crutch. She would rather you use that as kind of a tool to bring some awareness to the area,
mm-hmm.
and maybe check in with some breathing stuff every now and then. And then when you take it off, you can still feel it on you. And so you can do the pattern with that. And then ideally we can load it. And the idea is we want to make those patterns stick, and we want to make those positions and postures kind of easily accessible,
mm-hmm.
I guess would be another way to put it.
There's I don't think we talked about it yet, but there's the way I was using that dead bug and also some other stuff. There's you ever done so many bicep curls, you walk out of the gym and you feel like you can't move your elbows anymore?
Have you seen my arms?
Yeah, you did a bunch of thigh masters, it looks like.
Did you hear it pop?
Yeah, did you just adjust your elbow?
Yeah.
But yeah, so like just that phenomena for me is, I'm not saying I'm trying to get someone go into like a mini rhabdo or anything like that, and this is for special circumstances. But if I feel like someone is constantly defaulting to, let's just say if they're open in that lower cross syndrome thing, I feel like if the front side wall or even the oblique slings on front, if I can, it's the feeling that I get with it is like, how you take saran wrap and you put on the table and you put a heat gun over it and it just wrinkles. You get to that point where like a muscle feels like it's kind of like that. It's like they're completely gassed out, and then they seem to retain the same positional change, at least with a little bit of guarding, and not guarding in a bad way. It's almost like if they're arching or their ribs are flaring, if I were to just pull their shirt down and walk around with them all day. And it seems to stick some, even people who have like hip impingement, it seems to help because it raises the rim. It seems to help out with people with a Maignes syndrome. We didn't talk about Maignes.
Right.
But so that's what I'll usually do if they'll be tolerant to it. But then the deconditioned person, then I'm risking like killing them almost.
Right. It's funny you bring up Maignes. I mean I've actually seen that decent amount.
You've seen Maignes?
Mm-hmm.
Huh.
I actually had a case where a patient had definitely one hip surgery, maybe even 2 hip surgeries with no, to fix the labrum, a torn labrum, and no resolution of the pain. And then we did like rib depression, breathing, intra-abdominal pressure, and the pain went away. Mm-hmm. Needless to say, they weren't very, very happy.
Right. There was a girl I had here that she had pain with it was lat activation, I guess. So she was seated and she would drive her lat down into my hand, and she mainly had pain with pull-ups. So I had her do some pull-ups. It was painful. I put her into more of a hollow position, or at least assisted her into that a little bit, and she did pull-ups no problem. And yeah, she's like, "You telling me this is an ab thing?" I'm like, "Well, maybe it's probably a torso thing." But
yeah.
I should correct. When I said those 4 things earlier, I was reading off of Maignes, not Fassett Syndrome.
Ah.
There you go. That'll be in the article, everybody.
Yeah.
So as we close up here, is there anything you want to add on this?
We could go down some rabbit holes, but I don't think that we have enough time for those.
Right. Well, I think I'll try to tie it together nice in a bow here. I think that if you have a syndrome person, then perhaps we look for differentiating factors first to confirm there is or is not a muscular injury. If it looks like that area is bearing fruit, go down that route and try to get the person to become empowered with it. Doesn't mean you can't use tissue work or any of the other tools that you use, but at the same time, make sure that you're not leaving some supportive systems on the table.
Yep, I agree. And a lot of times, if you're looking at back spasms or something like that, instead of just diagnosing or trying to treat the back spasms, you kind of have to ask the why. Why are there back spasms? Or if there's a trigger point somewhere, ask why is there a trigger point. Don't just attack the trigger point in order the spasms to calm those down.
Mm-hmm. Those might be protective.
Absolutely. Most of the times trigger points are protective.
Yep. Darn trigger points. Are you going to help me close the show down?
Close it down?
I've never had a co-host to close it down.
Yeah. Well, I think I haven't either. So
you're not going to say what did Ron Burgundy say? Say classy, San Diego. You got to have a closing line.
Yeah. Yeah. Hoo-yah!
So actually, do you have a contact you want people to reach out to you with? You're not in clinical practice anymore, but
not practicing currently. But yeah, if you can feel free to either email me at drcodydimak@gmail.com, or hit me up on Instagram, still at maxperformchiro.com. So it's at maxperformchiro.
It's funny. I was trying to do some closing stuff, some mock closing stuff earlier, and I was referencing your name, and I realized I didn't know if there's a C in it or not.
No C. No C, just Dimak. Yeah.
Got it. Okay, everyone. So if you're looking for the show notes on this, go to p2sportscare.com, and there is a pretty comprehensive search function there. You can definitely go through and check shit out. This is going to be session number 105. So you just type a 105, no pound or hashtag sign, or you can probably look up Cody's name. I think you're only on 2 of them, so one of them will pull up. So that's where the notes are. And any references that we've made, I know we talked about the article as well as a poster and all that kind of stuff. I'll put links in there so you guys can see them. And any topics that you do want to hear about, or if you have questions or think that we're full of shit or whatever, just email us as well. Just keep it classy, San Diego. Booyah. My email is seb@p2sportscare.com. And Cody, you got anything?
No, I mean, especially if you think some of the stuff is BS, because I mean, that's start some good dialogue and talk some stuff over, and just to kind of let everybody know, we don't think that we know everything. That's for sure, and we don't. We're both Seb and I are continually learning. We're always doing a lot of research. We're trying to learn, trying to better ourselves. So, if you think what we said is total BS, then let us know.
Yeah, and also too, I'll just make sure that I'll mitigate a bunch of emails on this right now. Is that if you feel like there is no science or research to validate these concepts, you're probably right. And actually, just after this, the following podcast is 106. I interviewed a researcher, Dr. Andy Galpin out of Cal State Fullerton, and we discussed that. So he said that actually a lot of stuff in clinical practice has no science to validate because it's the human is so many variables that we can't control. So listen to that podcast, and will help guide you down the thought of there is no science to prove some of this, because we both recognize that. It's just what we've observed in clinical practice, put shit together.
That's absolutely.
Cool. You want to hear my closing?
I do.
Mine is leave people better than how you found them and date an Eagle Scout. You would. My closing is football season is upon us. So, who dat? Who dat? Who dat? All right, we'll close it off here. Talk to you guys next week.
Yeah, you're right.